Did you know that starting dysphagia intervention before and during head and neck cancer treatment is now considered a best practice? Yep, it's called prehab or proactive dysphagia intervention, and it can make a big difference in dysphagia outcomes. Let's break down what proactive dysphagia treatment really means and how to make it work in the real world. Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Brooke McGivern, a clinical SLP, doctoral student, and an expert in the area of head and neck cancer. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome, Brooke. So glad to have you here today. Can you share a little bit about yourself, how you're involved in the world of speech language pathology and specifically head and neck cancer?
Hi, Sarah. Thank you so much for having me today. It's an honor to be here. As you mentioned, I am a practicing speech language pathologist. I currently serve patients in the acute care, inpatient rehab, and outpatient setting. And I am also the director of marketing and communications at Tim's Medical, and I teach a dysphagia course at the graduate level. So I have a variety of interests, but one area that I'm very passionate about is head and neck cancer. And that passion really began as a graduate student. I originally thought that I would pursue a career more focused in the neuro realm. However, I had the opportunity as a student to travel to MD Anderson for a total laryngectomy conference with several of my friends. And seeing how integrated the speech language pathologists were with the physicians and the surgeons really sparked my interest and passion for this patient population because I learned about the immediate impact that we are able to have for these patients. So after graduation, I pursued a role in that area and ended up moving to Kansas City, where I had the opportunity to help develop a proactive program for individuals with head and neck cancer. And my experiences at that time were pivotal in my career, leading me to continue to pursue opportunities today, which can help improve advocacy and awareness regarding this topic.
Wow, awesome. And I think that's a really cool example for any grad students out there listening is like take those opportunities in grad school, right? Because you never know what might spark your interest and shift your career trajectory a little bit. So I'm really excited that today we get to talk about the head and neck cancer patient population. And when I was preparing for this podcast, I was interested to learn that the prevalence of head and neck cancer is going up and then survivorship is also going up. So the opportunities that SLPs have to work with this type of population is going up. Um, Given that context, what do you think SLPs need to understand as we start the conversation about the prevalence of head and neck cancer and how common dysphagia is in this population?
Yeah, that's a great question. Regarding prevalence, I think it's important that we as speech pathologists understand why prevalence is increasing. So we'll start by talking about the causes of head and neck cancer. So listeners may or may not be familiar with causes of head and neck cancer, but historically we've always talked about causes of head and neck cancer being related to alcohol consumption, tobacco use, dietary factors, and environmental exposures. Additionally, the use of alcohol and tobacco produces a synergistic effect, meaning that if an individual uses both alcohol and consumes tobacco, their risk of cancer increases exponentially. However, what we've seen in recent years related to increased caseloads of patients of head and neck cancer is the human papillomavirus or HPV. So many listeners have probably heard the term HPV before when you're going in for checkups as a child and then into your teen years, but this is aiding in the rise of head and neck cancer, and it is due to the fact that HPV is the most common sexually transmitted infection. So, why is this important for us to be aware of this as speech language pathologists? Well, in my own career, I've had patients come into the outpatient setting with their spouses or significant others not being familiar with HPV and its roots, if you will, and so this can bring up questions within their relationship about, well, how did my partner, the patient, how did they develop this sexually transmitted infection? So you may be faced with that in your office. So it's important for us to be aware of HPV and the fact that HPV does increase the risk of oropharyngeal squamous cell carcinoma, but additionally, it can actually be contracted from one sexual interaction and lay dormant in the body for years. So, why is that important? Again, because if someone's coming into your office asking you questions about infidelity and their relationship, it's really great for us to be familiar with the causes of HPV and that this could have been contracted, 10, 15 plus years ago and lay dormant in the body. And I share that because I've actually had that experience in my own practice. And thankfully, I was aware of HPV. But for those who are maybe just dipping their toes in the head and neck cancer realm or not familiar with HPV, I always like to discuss that. And of course, then that can cause cancer development in people very young. In recent years, I've seen people as young as in their 30s, 40s, and 50s.
Mm. Yeah, and that's really a new angle then to the because that wasn't kind of like the typical population who was getting head and neck cancer, and that has different implications for kind of in our rehab world.
Definitely. And along that note, just when we're thinking then about survivorship, as you mentioned when you asked this question, survivorship is increasing, and part of that is related to the disease related to HPV contracted cancer, but also the age. So, a lot of times these patients are younger, they have less comorbidities, et cetera. But when we're thinking ramifications and long term survivorship, if you have someone in their 30s or 40s, hopefully they have 40 to 60 plus more years of life ahead of them. So, as speech pathologists, when we're thinking about our treatment plans and how do we help patients not only just survive and get through cancer treatment, but how do we help them thrive and get back to living life on their terms? We know dysphagia is highly prevalent for this patient population. So, how can we as speech pathologists play a role in really helping these patients reduce decisional regret, which we know is high in this patient population, and even suicidal ideation. So,
Wow. So, today we're going to really focus our conversation on dysphagia intervention. And the concept of prehab has emerged as a best practice for this population. Can you just give us a high level view? Like, what are we talking about? And what's some of the recent research saying?
definitely. So, I usually refer to earlier intervention in this patient population as proactive intervention. People with head and neck cancer do often develop dysphagia, but they may actually have some level of dysphagia prior to treatment beginning. So, think other causes of dysphagia such as esophageal abnormalities, etc. So we need to be thinking about the whole picture, and we can really help patients be successful by obtaining baseline imaging. Additionally, I think it's important to think about the scope of practice of the speech language pathologist. ASHA has a really nice resource that details the 8 domains of the speech pathologist, under which falls prevention and wellness. So, when we're
Hmm.
thinking about people with head and neck cancer, we know, like I said, that they are highly likely to get dysphagia, and the etiology of that dysphagia is multifactorial. Some of the issues that they will experience are xerostomia, dysgeusia, odynophagia, head and neck lymphedema, trismus. There's a multitude of things. So, from the speech pathology standpoint, we need to be thinking about the entire picture, not just one segment. So, there's a lot of different ways we can do that. The biggest thing, as you mentioned, with prehab is really being proactive about the swallow function itself. So, thinking eating and drinking and exercising through treatment. And then, additionally, as we'll discuss today, looking at lymphedema. In a study conducted by Jeans et al. In 2023, they found that lymphedema is highly prevalent, with 96% of people with head and neck cancer developing some form of lymphedema, which not only impacts swallow function, but airway integrity as well. So, just thinking about all of the ramifications and how can we help patients have a better understanding of these issues and be proactive in management.
Mm. I'm just going to do a follow-up question from that. So, when you said, okay, like we want to start with imaging just to get a baseline, do you feel like you for sure would do that with someone who's having some type of dysphagia complaint, or are you seeing us moving more toward like standard practice if someone has like head and neck cancer and they're at risk for developing dysphagia because of the treatment or surgery or whatever, would you do it kind of on the front end, or I just want to make kind of pick your brain about that.
Yeah, that's a great question. So, in my opinion, because of the high likelihood of dysphagia and lymphedema for this patient population, if you can get some form of imaging at baseline for all patients, that is my
Like kind
recommendation.
of the gold standard.
Yeah.
Okay.
Often asked, should you do a FEES or an MBS? Yes, a FEES or an MBS. And I think that goes back to your clinical practice. And as I mentioned, these patients do often suffer from decisional regret due to swallowing. And they also suffer from appointment fatigue and financial issues. And because of that younger patient population, a lot of the patients I see are still juggling full time jobs. So I think if we can piggyback with like ENT or radonc to review their endoscopic images, we can get a good look at the lymphatic system, the vascularity of the area, and then we could do a modified to get a look at the whole swallow continuum, and that can kind of help decrease the amount of scopes they're doing, appointments, etc.
What is the decisional regret that you are mentioning? I don't know that I've heard that term before.
Yeah. So decisional regret is um, the lack, or excuse me, the regret that the patients have from participating in treatment for head and neck cancer. In a study conducted by Gill et al. In 2011, they found that the primary reason that people with head and neck cancer have regret for pursuing treatment is related to swallow function, which is very
Mm.
impactful for us as speech language pathologists, I think, to realize the role that we can have in helping to reduce that. So, as I mentioned, these patients have so many issues that they experience both during treatment, but then also after. Because unfortunately, I've seen many patients that think, well, I'm going to have issues during treatment, but after I'm going to get back to living life how I was before. And unfortunately, we know that therapy is absolutely crucial for improving patient outcomes, and we can't always predict what long-term issues patients will have, but we do know that dysphagia and lymphedema are very high.
Mm. Wow, that's really powerful. And yeah, really speaks to why it would be important to get a plan going, kind of in this proactive mode. So, that's a great high level view. Let's just dive into it then to like our clinical practice as SLPs, like how kind of the big idea of this proactive treatment, what does that really look like with these clients in our one-on-one moments? And so, first of all, I'm just thinking about the clients that we're thinking about this with. So, are there certain considerations that could impact like who we would do this with, or like what might impact their participation in setting up a proactive dysphagia treatment program?
Yeah, that's a great question. So, in my opinion, I think everyone deserves an option for proactive intervention and that they deserve the initial education and counseling to be aware of what's out there, what resources are accessible. However, I think we can all attest to this depending upon where you're at, there may be different barriers to access to care, including therapists in the area that are skilled in these various areas that I've mentioned, what their support system is like at home, and then other health issues. So think, cognitive deficits, chronic illness management. Additionally, financial considerations can also be of concern. So there can be a lot of different factors that can impact a person's ability to participate in a proactive treatment plan. However, I try to approach every patient in the same way that they're going to get some sort of baseline imaging, and then I present the information to them regarding what they may experience during treatment in terms of swallow changes,
Mm.
as well as ways to instill hope in them for positive outcomes. And then, depending upon what the patient's barriers are in response to the information is regarding my recommendations for treatment during head and neck cancer intervention and a home program, then I try to tailor the therapy to their needs. For example, if I've got somebody that's working full time and they have a lot of things that they're juggling and they don't want to, or they can't get into in person, maybe we only focus on an at home program. And then I do, phone check ins, or maybe I have somebody that has expressed that they are a little bit more anxious and worried about the treatment and they want to come in once a week, every week during treatment. It really just depends on the person.
Yep. Okay, that makes sense. So I imagine then when you're doing that first assessment type of visit, then some of your assessment time is providing the education just about like what that long-term impact could be on the swallow function. And I I'm thinking about the patients who maybe like they don't have a drastic swallowing complaint yet. Um, how do you have any like talking points or strategies to share, like how you go about that conversation? Because I know as a speech therapist myself, like you kind of feel this burden of like explaining it in a serious way because you want to get that like buy-in, carryover, like that is what's needed. But at the same time, like these people are kind of facing big emotional weights right now. So I don't know, kind of trying to balance the seriousness, but also not like just destroying their hope.
hmm Yeah, that is a really important point. Listeners may or may not be familiar with the term nocebo effect, but as healthcare professionals, we unfortunately can negatively impact patients in the way in which we provide information or education. And so it's important. It's an important balance and line for us to provide the information for patients to make informed decisions, but also elevate hope, like you mentioned and like I mentioned. So, ways in which I do that, like I said, I do discuss the act of being proactive in terms of swallowing, and I've had patients that say, I don't want to do a baseline modified or fees. I'm swallowing just fine right now. But what I encourage is that people dig in and do utilize patient reported outcome measures and questionnaires and things of that nature, because oftentimes these patients are very tough, strong people. And they're saying, oh, I don't have a lot of swallowing issues because they're so focused on disease eradication that they maybe aren't sharing with you that they've been coughing for several months and they're already sleeping upright because they're having difficulty breathing or choking at night. So I think, one, spending time really kind of digging in with the patients and asking some questions. And if they're still, not necessarily open to doing therapy, just meeting them where they're at and giving them information for home management. So I have, packets that the patients can take home. And then I will ask them, is it okay with you if I do phone check-ins? Then I just want to be here to support you throughout this treatment. So I do discuss, like I said, things that they'll notice, primarily really encouraging oral intake and swallowing exercise during treatment, and then lymphatic management are the three big things that I hit home with every patient.
Awesome. Yeah, I think that's really good advice. Like, we don't have to like right away move into like, well, this patient was like non-compliant or declined treatment or some of that like harsh language, right? But because you're really starting the relationship with them. So if like that day is not the right day, I think if you like approach it the way you just described, then it gives them like a freedom to contact you. You're like, you know what? I actually thought about it and I think I do want to like come back in. But I think if we are like, well, that's, kind of talk to them in a negative way, then we don't establish that relationship where they could like tell us how they're really feeling.
Yeah, I actually have a really cool example of that. I had a patient a few years back that came into the acute setting and had severe dysphagia, severe internal fibrosis. We did the fees and he was aspirating pretty much everything. I gave him all the information, the things that we could potentially do to work together. And he said, I'm just so overwhelmed at this time. I just want to do a feeding tube. Um, so that's what happened. He had the feeding tube. I gave him my information and said, if you change your mind, call me. And he ended up calling me. And we had a really successful treatment program together. And he was able to get his peg tube removed several months later. So I think it's like you said, I hope that our field is kind of moving out of that phase of using terms like non-compliant because patients, all patients, not just head and neck cancer patients, but all patients are human beings. And there's so many things that may be hindering their access to therapy or willingness or ability at that time. So just like you said, just remaining open.
Awesome. Okay, so let's say you have a client and they do want to do this dysphagia intervention during their head neck cancer treatment. Can you give us some examples of like how often do they actually come to speech therapy, or what sort of goals are you looking at? Just wanted to hear what it looks like for you.
Yeah. So, like I mentioned, the frequency of treatment really will depend on the patient. But the key things that I hit home for every patient are the swallow musculature itself. So, we see in the literature, specifically, I'll cite two articles the Hutchinson et al. 2013 article, and then the publication by Carnaby et Mann in 2012. We find in those articles that patients that conduct swallowing exercises and oral intake during treatment have the best outcomes. In the article I mentioned by Dr. Hutchinson in 2013, they found that those who eat and drink and exercise have the highest rate of return to a regular diet and the shortest duration of feeding tube dependency. So it's really crucial, in my opinion, that patients are doing swallowing exercises. And when we think about exercise physiology, actually swallowing things. So eating and drinking. So sessions often for me include doing swallowing exercises and some sort of oral intake. I tailor it again to the person using those principles of exercise physiology and focusing on progressive overload. The other component that I think is very important that I've mentioned a few times so far in this conversation is the lymphatic component. So we do see in the literature that patients with head neck cancer are highly likely to develop internal and external lymphedema, and that can even be at the time of cancer diagnosis. So oftentimes I include manual interventions in as goals for patients with head neck cancer. So I'm talking about lymphatic management with the patients, skincare, um, external and intraoral massage, as well as stretches and things of that nature to keep everything nice and mobile and to keep the lymphatic system moving. So, those are some of the things that we talk about in sessions. And then, additionally, I typically recommend expiratory muscle strength training. Dr. Hutchinson and colleagues have a publication about this discussing the max expiratory pressure improvements for people with head neck cancer that use EMST. So in my clinic, we typically use EMST 75 light or 150 in our practice to help with airway clearance and swallow function.
Awesome. Okay. Could be a dumb question. I'm someone who does not treat this population, and I feel like the topic of lymphedema management for dysphagia is new since I was like in grad school. So I'm just going to ask a little tangent about that in case anyone else is in the boat that I'm in. Like, what if someone's like, "Oh my gosh, I never learned about this and I've been seeing head and neck cancer." Like, where do they even begin on this topic? I mean, do you have to go get a certification? Do you have to do a course? Like, is it considered a best practice? Like, can you give us a little bit more info?
Yeah. Yeah, that's a great question. So, if you didn't learn about it in grad school, that's okay. Take a sigh of relief. I didn't learn about it in grad school either. And that's actually what I really attribute to the plateau that many of my patients in the beginning of my career had. And maybe if you're seeing people with head neck cancer and they come into you and say, "Hey, Sarah, like, why on some days can I eat a cheeseburger with bread and then other days I can't?" Part of that is related to the lymphatic system because there's fluctuations in the internal and external swelling. So, getting to your question about what should we do if we aren't familiar with it, there are a lot of free resources to learn about head and neck lymphedema. I've done a lot of presentations and talks about this that you can find online. Additionally, you can start diving into the literature. Jessica Greger and colleagues just did a publication in 2024 discussing the use of advanced pneumatic compression for internal lymphatic treatment. So that's actually where I started when I learned about the lymphatic system. Was I wasn't certified in manual lymphatic drainage. I was certified in myofascial release. So I was using myofascial release in conjunction with advanced pneumatic compression, which is FlexiTouch. So patients would come in, they would sit in the FlexiTouch, which is just a device that mimics manual lymphatic drainage. And then we would do our progressive overload that I mentioned. And why is that important? It's important because when we do fees, we see that the internal lymphedema is directly impacting swallow function, airway integrity. So if I can get that swelling down, I have better results with the swallowing exercises that I'm doing. So I would recommend those things. But then to learn more, I think taking a course is great. I personally took the Norton Head and Neck Lymphedema course. There's also a course through Chow that's taught by Dr. Mallory Moore, who's a CLT Lana, and she's a speech pathologist. So that's a great one. But any type of manual therapy is going to be beneficial. I also want to encourage you that if you're recommending swallowing exercises or oral intake, you're already impacting the lymphatic system, which is great. That's a huge win. The more we can get those muscles to contract, the better we can move that lymphatic fluid.
Awesome. Yeah, and I hear a lot of great little tidbits from you. So, like in our handout for the show episode, maybe we can just put some of those like article references or links so that people listening can find those also. Okay, Brooke, guess what time it is? Wild card question time. Okay, here is the wild card question for today. Do you have any quirky habits or rituals that help you get through your day?
Well, yes. I would say my biggest quirk is that I always have a cup of coffee next to me somewhere, and it's probably ice cold, and I'll still be drinking it throughout the day. I don't know why. It's just like my motivational cup. I've got my cup right here,
Got it
actually.
right there.
Uh, Usually, if you're around me, I typically have multiple drinks, but I always have a cup of coffee, and it's usually cold by the time I get to it. So that's the big one. The other thing I do is I try to meditate at times throughout the day just to kind of, like get my composure, especially when you're working with patients and patients with head neck cancer. You want to have calm energy. So I juggle the caffeine intake with meditation.
Love it. That's a very good balance. Awesome. Okay, so diving back into our topic at hand here, when you're talking about like eating, swallowing exercises, lymphatic management, something that's popping in my head is just like wondering what you see with clients for how much you have to do versus how much you transfer it over to the client. And that kind of just ties in with that like home program idea. So would love to kind of hear your experience or like kind of what you expect of patients to manage like on their own with a home program. And yeah,
Yeah.
anything.
That's a great question. So, the swallowing exercises and the oral intake, I put a lot of emphasis on that for the patient to do on their own. And again, this is going to be specific to what you found in that baseline imaging. Some patients, their swallow is so impaired at the time of diagnosis that they may not be able to do oral intake. So remember that you want that baseline imaging so you know what can my patient be having during treatment. However, if a patient is doing exercises and having oral intake during treatment, I really emphasize that they need to be doing that on their own at home. And then when they come into clinic, I can spend more of my time focusing on that manual techniques. Now, if possible, I try to train caregivers regarding the manual interventions. So if they've got someone that can help support them at home, I show them as well so that they've got that additional support. And then I mentioned advanced pneumatic compression. That's a device that they can actually get at home that is covered by insurance. And typically, patients aren't going to actually be using the full chest and head garment with that until after treatment's completed. However, they can always use the chest garment during treatment.
Okay, and that's part of the lymphedema management then too? Yep.
Yes. Yep.
Okay.
So surgeon usually will I spend a lot of time, like I said, with the manual techniques, but then I also try to add in the exercises and oral intake as possible, as well as EMST. So it's a lot to kind of put into the session, but I juggle the interventions based on what's going on with the patient.
Definitely. So, along that same line, do you find like you have any strategies to help them do that more independently, or like are you like, okay, we're going to put them on call once a week and check in, or have you seen any head and neck cancer facilities kind of have like a successful like strategy for staying connected with clients who might be like post their treatment and so they don't need to come in like once a week?
Yeah, that's a great question. So, in my experience, we have a really great relationship with the radiation oncologist team. So, the nurses and the physicians, as well as the ENTs, which really helps with that carryover. So, like you mentioned, if a patient has said, they don't want to come in for therapy, and they want to pause, typically the rad onc nurses in my current practice are calling the patients, they're checking in, they're also coming in for check ins with the physicians. So, that additional education from the radiation oncology team and ENT team can be beneficial. And then, if they're open to it, like I said, we actually, as speech pathologists, will do the check ins as well. So, again, as we've discussed, there's a lot of issues these patients experience. In my opinion, if I can even just help patients decrease or eliminate one symptom, it's a win. So if it's, getting the patient to do swallowing exercises and maintain an oral care regimen, that's a win. If I can get them to do all of the things, that's amazing. But like I said, these patients have so many things going on that can be very difficult. So it's really just tailored, but that interdisciplinary collaboration is key in patient success.
That's a great reminder. Just it doesn't have to be like all or nothing, right? So how often do you see people going through like radiation treatment and then maybe having like a change in their dysphagia symptoms or ability? Do you find like how often are you having to adjust what you've been recommending for them?
Yeah, that's another great question. So, as I mentioned, there are a lot of issues that pop up during treatment. I mentioned a couple at the beginning of this conversation. Odynophagia, so pain with swallowing, dysgeusia, which is alterations in taste, oral mucositis, xerostomia, all of those things can occur at, at you know, at any point during the treatment, as well as lymphedema. So, patients, even who might feel like their swallowing isn't very impaired at the beginning, often will experience one or some of these issues during treatment. And so, at those points, then we're going to be getting calls from the patients, or if even if they were on our caseload, we may need to adjust how much they're doing the swallowing exercises or what their oral intake looks like based on their presentation. Some of the things that I just mentioned additionally will require interdisciplinary support. For example, oral mucositis would need support from the physicians, and even lymphedema. I think it's really important to loop in our certified lymphedema therapists who could be PT or OT to help address that. So it's again, I'm sorry because it's not like a concrete black and white answer, but it is patient specific. And some patients, they want more of that support. Like we have a patient on our caseload that we've been working with that she does like to see us more frequently, especially when new issues arise, so she can kind of troubleshoot and figure out what the best path forward is.
Totally. Yeah. And just kind of like freedom, like it's not all on you, the SLP. Like build your team, make sure you know who your team is. So you have those other professionals if you feel like over your head with things. So, kind of on that note, I can imagine some SLPs listening could envision, like, you know what, I think we need to be doing more proactive dysphagia treatment, but maybe they're part of like an organizational system that doesn't yet have the organizational pieces ready. Like they're not getting those automatic orders put in or referrals. Have you worked in places where you've seen this go well, or do you have any advice for SLPs who might recognize, like from an organizational standpoint, they need to make some improvements in order for us to be doing what's considered best practice?
Yeah, that's a great question. So, as I mentioned, in my first clinical setting, I helped develop a proactive program, and then I became the district oncology lead where I set up programs that were replicated from the original program I developed. So, I have a lot of experience
Congrats.
in this. And the biggest piece of advice I would say is get in front of the key decision makers. So, in the head and neck cancer space, a great contact to have is the head neck nurse navigator. Not every location has a head neck nurse navigator, but many do. Additionally, the advanced practitioners are great to connect with because they have a little bit more time usually to spend with the patients and then getting in front of the physicians as well. So, if you can, I recommend doing like a lunch and learn or a morning meeting with everyone to talk about why you're there and what you're wanting to do. And then, if you're able to, get involved with the tumor board because tumor board is where everyone on the team is going to get together, discuss the cases, and talk about what interventions are needed. So if you're there, if you can at least get your foot in the door, show your face there, and talk about why speech pathology can be beneficial, you can start the referral process. Once that gets going, like I said, I really recommend that you get a concrete referral process in place and train people within the team. That's a big mistake that I've made in the past is that the program was dependent on me being there, like me as a human being. And when I left, the program fell apart. So getting in order sets similar to like if you're in acute care and you've got a stroke order set, getting some sort of order set in place, and then also working on training other people within your team to ensure that if you were to leave or have something happen where you couldn't be there as much, there are other people on the team who can provide the services.
Great advice. Okay, so this has been really great. I feel like you've provided so many amazing pieces of information. So, if we're going to talk maximum impact, what would be your top 3 actionable takeaways for our listeners to put into practice?
Yeah. So, as we've been discussing, proactive intervention is absolutely key. We want to encourage patients to eat and drink and to complete a home swallowing exercise program during treatment for head and neck cancer if possible. If for some reason a patient can't have any sort of oral intake, then really hit home the importance of those swallowing exercises. Additionally, like we talked about, lymphedema is a critical piece of the puzzle for both acute and chronic issues and acute and chronic dysphagia for this patient population. And we can, at the very least, play an important role in providing education and counseling, but we can also go a step further and provide intervention options. So, a couple of things we can do is encouraging those swallowing exercises, having them sleep elevated, compression garments, and then manual intervention. And then last but certainly not least is interdisciplinary collaboration is crucial. As we've discussed, these people experience a multitude of acute and chronic issues, and many of these require a multimodal approach and may include pharmaceuticals, medical equipment, specialized intervention, and in some cases, even surgery. So it's crucial that we're building rapport within the team and ensuring open communication to support patient success.
Awesome. Fantastic. That is great advice. And I would love to hear you apply that to a like hypothetical but clinically applicable example so our listeners can just kind of hear how that plays out.
Sure. So let's discuss a case, just a hypothetical case in which a patient's completed concurrent chemotherapy and radiation treatment. This is very common that patients will experience both chemo and radiation. And let's say that this patient was not referred to the speech pathologist during treatment, but he's referred 1 year after treatment and has been PEG dependent for almost a year. It's important to note that sometimes, even with a PEG tube, patients may be malnourished. So, in this case, the patient's malnourished despite having the feeding tube use and due to the dysphagia and other issues, has become isolated. Symptoms following treatment may include severe oropharyngeal dysphagia and esophageal dysphagia, internal and external lymphedema, fibrosis, xerostomia, and trismus. So, what would treatment look like? Treatment would include manual intervention. So, that's more along the lines of myofascial release. So, it's massage of increased pressure compared to manual lymphatic drainage, which is a lighter massage, which I would also recommend to address the lymphatic system. Compression garments, again, to help mobilize that lymphatic fluid. Advanced pneumatic compression for home use, which is the FlexiTouch device that I mentioned to utilize at home to address the lymphatic system and swallow function. Swallowing exercises and oral intake, and then potentially dilation. So I often see that this patient population has an issue with UES function. So it could be that dilation could be beneficial. So um, these things could be beneficial, and in this hypothetical case, would help improve the patient, improve swallow safety and efficiency, and returning to an oral diet.
Mhm. Do you often find that's a good example? Do you find like you might be the first person to recommend that they follow up with like GI for a dilation? Like that's something that you might be the first person to like push that along?
Yeah, yeah. So some cases where the patient actually comes in and says, I was having issues with swallow function, and I told my doctor and I was referred to GI and I had a dilation, which actually increased the issues with swallowing, but and they'd never seen speech pathology. And when you think about etiology and why would that be? And my hypothesis is that when we think about dilation of the upper esophagus, it is trauma to that area. And if their lymphatic system hasn't been addressed, then that intervention could increase the severity of lymphedema in the short term. So sometimes it's that we're the ones as speech pathologists suggesting it, and sometimes, un- unfortunately, they've actually had it done before they see us and have had potentially negative consequences. It depends again on that lymphatic severity.
Very interesting. Do you have one more clinical example you could share?
Yeah.
Okay.
So, in this example, the patient's admitted to the hospital in the acute care setting due to respiratory issues and is diagnosed with aspiration related pneumonia. The SLP team is consulted, and the fees reveals severe oropharyngeal dysphagia and internal fibrosis. So, just a note if you're at the bedside and your patient sounds like this, and you see that they've had radiation, you can hypothesize they probably have lymphedema or fibrosis, but you can use fees to determine. So, in this example, the patient is 10 years out from treatment from head and neck cancer, which included both radiation and chemotherapy. And after the inpatient fees is reported, this patient says that they do not wish to participate in therapy, maybe due to the burden of head and neck cancer treatment previously, as well as previous interactions with speech pathology and a lack of improvement. So, in this hypothetical case, the patient opts for a peg placement and eventually decides to pursue outpatient therapy with speech pathology. So, at that time, we could again utilize a manual intervention. So, that would be the more myofascial release style of intervention of increased pressure, manual lymphatic drainage, compression garments. Chip packs are another thing I didn't mention in this conversation so far, but they're just packs that can help break up fibrotic tissue that we can actually make in clinic or the CLT can make. Additionally, I would recommend swallowing exercises, progressive overload with boluses, as well as advanced pneumatic compression. So I have had cases very similar to this. And if a patient is that far out, 10 years out, and they have fibrosis internally and externally, you can anticipate that treatment needs to be pretty aggressive. And you can make success, you can have success, but it might take a little bit longer. So we're thinking, 6 months to a year, and you will most likely see improvement. So in cases similar to this in my own practice, I've seen patients be able to return to an easy chew diet and thin liquids even after having fibrosis internally and externally. But it really depends on the patient, and we want to set that expectation that they will need to manage the lymphatic progress.
Yeah. Wow, that actually makes me feel like hopeful, right? Because patients have in this case, like a patient would be living with this for like a decade, feeling like this is just the way it is, and it's pretty cool to hear that there's reason to do therapy. Progress can be made, even though, yeah, it's going to be a commitment. That's pretty cool. So, Brooke, you know your stuff so well. I have loved this conversation. Can you tell people like how to follow along with some of the work you're doing?
Yeah, definitely. So the best way to reach me is just through my Instagram. You can also, if you have a question, always send me an email. It's my maiden name. So it's brooke.beelman@gmail.com if you have any questions. But as I mentioned, I'm also the director of marketing and communication at Tim's Medical, and we host free webinars, and we have several on this topic. One by Jessica Greger, who I mentioned in this conversation, who's doing the work with advanced pneumatic compression in TIMS, measuring internal lymphedema, which is really extraordinary. It's the first publication of its kind. So she has a presentation. Then I also have a webinar on our on demand offerings. So those are probably the two best places. But like I said, if you ever have questions, feel free to send me a message on Instagram or send me an email.
Awesome. Very good. Thank you so much for being here. To wrap things up, do you have any final words of wisdom or inspiration that you want to leave with the audience?
Yeah, I think the biggest thing is that when people start working in this patient population, it can feel overwhelming because there's so many things going on. So I just want you to remember that you can make a difference for people with head and neck cancer today with what you already know. swallowing exercises, oral intake, that impacts the swallow function and the lymphatic system. Um, we as speech pathologists have the opportunity to make a huge impact by applying basic principles and processes backed by research, and by encouraging your patients to eat and drink and exercise through treatment, maintain a good oral care routine, and address the lymphatic system. We can significantly help improve patient outcomes.
Very good. Thank you so much for being here. Brooke McGivern, you have given us some really awesome insights, clinical takeaways related to proactive dysphagia intervention for those with head and neck cancer. And thank you so much for the work you do with this population.
Yeah, thank you so much for having me.
Thank you for tuning in to this episode of SpeechScope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. SpeechScope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.